Hello, welcome everyone. We're just gonna take a few minutes, a couple of minutes for everyone, let people join and file in. So we'll start in about 2 minutes. Thank you. Okay, so maybe we'll get started and people can just join as we go. Hello, welcome everyone. My name is Cary James and I'm the Chief Executive of the World Hepatitis Alliance. And welcome to this online event, Turning the Tide for Hepatitis. I know everyone is very busy with their World Hepatitis Day activities this week, so we really appreciate you taking the time and sharing this time with us for this important topic. So just maybe a little housekeeping before. We do have interpretation available. So if you just look on the bottom of your screen, you'll see a little globe that says interpretation. Just click on that and choose your language, and then um, you should receive all of the presentations in your chosen language. We really want today to be, a kind of free-flowing discussion and exchange of ideas, not just with the people on the panel, but also between all of you. So please do raise your hand if you have any comments or questions, or you'd like to share some examples of your work. That's really one of the big things that we want to achieve today. So please don't be shy. Please do that, and then we'll call on you. We're going to have three sections looking at really some of the biggest issues today in hepatitis elimination. Because we know that even though there's such amazing work being done around the world, and we have had some great successes, the latest Global Hepatitis Report does show um, that we still haven't turned the tide in hepatitis. But there is a window of opportunity between now and 2026 that we can really get things back on track and get more countries closer to that goal in 2030. So today we're going to look at three areas that are key to this, to turning the tide in hepatitis: testing, access to treatment, and prevention, and specifically PMTCT and birth dose vaccine. And we're very blessed to have experts from around the world who can share their wisdom and their insights in these areas. And then, as I said, we're really looking for you to also contribute to the conversation so we can have a real global view of these issues and how we can turn the tide and really move progress forward. So I think that sets the stage. So we're just going to start with the Global Hepatitis Report, the new data. So I'm very pleased to introduce Dr. Funmi Leshi, who's the hepatitis lead for the Global Hepatitis Program for the World Health Organization in Geneva. And she's going to start us off. So Funmi, over to you.
Thank you very much, Cary, and I'm just going to share screen and begin this very, very brief presentation. I find share screen, just a minute. Okay. Sorry, can you see the screen? Can you see my screen?
Yes.
Okay.
Maybe just put it in presentation. That would be perfect.
Okay. Okay. Okay, hello everybody, and good afternoon, good morning, wherever you may be. My name is Dr. Fumi Leshi, and I work with the WHO Global Hepatitis Program and lead the program. And just to say a huge thank you for inviting me to participate in this webinar. And I will start and set the scene by presenting the key takeaways from the Global Hepatitis Report, which was launched in 2024. I reiterate that reaching elimination of viral hepatitis B and C by 2030 remains the goal. And elimination is commonly understood as reducing the incidence of new infections of both hepatitis B and C by 90%, and reducing deaths from liver cancer and cirrhosis by 65%. Now, absolute terms have been defined for these impact targets. Now, I must highlight that although there are many, many important interventions, 5 priority interventions, when implemented at scale, have been defined for reaching elimination. And there's an elimination framework and a path to elimination, which have been developed and published. Now, the overarching strategic directions are shown on this slide on the left. And the progress to elimination can be measured using these standardized impact and program targets for 2025 and 2030. So I would present really the progress towards this elimination. And this Global Hepatitis Report is really the first ever consolidated report that provides both the latest estimates on disease burden as well as the status of access at global and regional level. It was an exciting development collaboratively and includes data from 187 countries. And the methods and main data sources are shown right there on your right. Now, there are 5 key messages of this report, and I must say that this is my most important slide because it contains the 5 key messages. The first is that the mortality is increasing. The second is the global coverage of prevention, diagnostic, and treatment are far below the global targets established for 2025 and 30. The third very important finding, we saw that many countries have plans. They have adopted WHO guidelines for scaling up the responses. However, implementation has been really variable, and testing uptake and availability of diagnostic care outside tertiary centers have been limited. It was clear in bullet 4 that access to viral hepatitis treatment has not yet shifted to a public health approach. So we have better tools than ever to prevent and diagnose, and it is time to take action to make elimination happen. Now, the rest of my slides, I'll just show data to support those 5 key points that I have highlighted, because I recognize that I have just a few more minutes to go. So these are the numbers: 254 million hepatitis B, 50 million hepatitis C. I think what is notable is the regional spread. For hepatitis B, 3 regions, Wipro, Afro, Sierra has the greatest burden, while for Hep C, it's more evenly spread. In terms of burden, we've talked about mortality increasing, mostly due to hepatitis B. Now, the incidence has declined indeed from 3 million, 2.5 million in 2019 to 2.2 million in 2022. However, looking at this graph that shows the trend in incidence and mortality, we can see clearly that HBV incidence has declined, but it's declining too slowly. And the HBV mortality has increased Unexpectedly, this may be because more countries are reporting data from the 187 countries. For hepatitis C, the incidence has declined and the death rate has declined, but still not on track. This slide shows the indicators showing progress in 2022 compared with the 2025 interim targets and the 2030 elimination targets. Have highlighted the strong progress in prevention, including percentage of newborns who have had timely birth dose. In 2022, this was 45%, and it was still less than the baseline for 2020. So we're far away from our target. How do we get to 2025? This is the same for harm reduction and needles and syringe injections. In terms of this slide, I'm just showing this slide to document the regional differentiation and to ensure that our interventions are shaped to addressing the key regions where there's suboptimal coverage and where there's lack of hepatitis B birth dose. And this in Africa was 17% for birth dose. Inadequate progress in testing and treatment. This is a slide we've seen many times, but less than 40% of HCV has been diagnosed, less than 15% of hepatitis B has been diagnosed. So we have the plans, we have the strategies. Some countries have the appropriate drugs on the essential drug lists, but very few countries have delivery at public healthcare level, showing that the public health approach really has not been fully explored. And for example, hepatitis B medicines on the left graph, they are available in treatment guidelines and some countries in the essential medicine lists, but few of these drugs are available in primary health care. And on the right side, you will show the services associated with user fees globally and every stage of hepatitis care, except perhaps in the region of the Americas and in the Eastern Mediterranean region, where strong programs have been built. This is the same for hepatitis C medicines, availability in guidelines, but the drugs are not available in the ground. In terms of birth dose, the costs are here. I will not go into these details because I think I'm running out of time. The point here is low-income countries pay a median price of 0.4 per dose of the monovalent vaccine and a little bit more for the pentavalent vaccine. We noted out-of-pocket expenditure in some countries can be an access to barrier to access to birth dose, and this really ought to be minimized to expand coverage of birth dose and other vaccination. So taking action requires implementation of strategies and plans. We have a lot of strategies and a lot of plans, but we need to implement. And these 4 key actions will support implementation: testing and treatment to reduce mortality. According to the modeling calculations, we need to test 30 million people need to receive hepatitis C care and 40 million people with hepatitis B. We need to find the strategy that works for treatment. Also, accelerating reductions in disease incidence and overcoming the barriers to hepatitis B birth dose. Increasing access to affordable commodities and reducing out-of-pocket expenses are key access barriers we need to work with. And of course, surveillance is key. So as we look forward to 2030, we have identified in the report some urgent priorities, including access, investment, and sustainable funding key. With data, I must talk about partnerships and collaborations. That's what the Gavi is going to provide. That's Global Fund and various other funders. We need that strong global and regional partnership. And of course, community engagement, without which we can do very little. Research and innovation. And on the right, I show Egypt and Rwanda that have made great strides towards elimination. And I would say thank you so much for the opportunity to present. Thank you, Anova.
Thank you so much for me. So if we'll open it up for any questions or comments from participants. So if you would like to ask a question about Funmi's presentation or make any kind of comment, please raise your hand or write it in the Q&A section, please. I mean, maybe just to kick it off with me, I mean, it was a fantastic presentation, really clear, but I guess as the lead of the, Global Hepatitis Program, I mean, what are your personal kind of reflections on what the report showed?
I think one of the most important thing that we noted, Cary, was that we have the tools that we need. I'm just trying to turn my video on. We have the tools that we need. We have multiple guidelines. We have strategies. We have few countries taking this up. It was quite interesting to see the access issues. So the drugs are in the market, the diagnostics are in the market, the hepatitis C self-testing was pre-qualified last week, but no one is buying them. They're not buying enough. I understand that, yes, there is no global donor, which will really have helped. If we had a global fund for viral hepatitis, perhaps that will change the situation. So the question is, how can we support countries to get this funding to take action? I think it is time to take action. We have talked enough. We have plenty of strategies. But how do we begin to take action in a landscape of limited financing? What innovations do we need? I think I'll stop right there. There's lots to be discussed.
Absolutely. Thank you so much. So I see, Gavin, you have your hand up. Could we turn on Gavin's microphone, please?
Kia ora, thank you very much. Funmi, that was a fantastic presentation. Thanks, great overview. So my former role was as the National Program Manager for the implementation of the HCV elimination strategy for New Zealand, for the New Zealand Health. Unfortunately, we've been through several iterations of national management in New Zealand with health reforms and various other factors. But one of the major issues that I did come across was there's a very clear delineation point between our primary secondary care and community-based care. And one of the big issues that we had was actually enabling the interpretation of that high-level strategy that is absolutely fantastic and is very visible, but creating an interpretation of that could filter down through and actually enable our local programming. So there's a real barrier there in terms of the communications between what we're seeing with World Health initiatives, which to me make absolute common sense, and actually interpreting that into action on the ground. So sorry, it's probably more of a statement than a question, but just something that I observed that did actually create really significant barriers to what we were doing there.
Brilliant. Thank you so much, Gavin. It's great to have that view. I think Ibrahim, I think you have your hand up as well.
Hi, good afternoon, everybody. I'm from Nigeria, so I want to share more light on aspect. Let me take for example, last week we did a sensitization on viral hepatitis in our community. Unfortunately for us to have the testing strips and the vaccine is very difficult for us because lack of funding and then the resources mobilization that we have within us is giving us a tough time. So I am pleading with WHD if they can have like maybe open a grant for us here in Nigeria so that we'll apply and then we'll be glad, and then our mission is to eliminate viral hepatitis in our community. So thank you, and over.
Thank you so much. I'm sorry, I was just having a little bit of problems with my audio. I'm sorry if there was a specific question that you had, Ibrahim. Could you please type it into either the chat or the Q&A, and then we can come back to it. Thank you. Rachel, Halford.
Thanks. Hi, Funmi. Thank you for a great presentation. I do have a really quick question. I was thinking as you were presenting, and it really bothers me that, this is the time for action. We have all these things in place, as you explained. I just wondered, is there learning we can take from COVID as a globe? Because, when COVID hit, there weren't really big plans in place. There weren't medicines. And very quickly, as a world, as a globe, it all came together really quickly. When you think about it in hindsight, over a couple of years, absolutely. And countries supported each other. I wonder if there's learning that we're not utilising here with this, in terms of the hepatitis, because we've got the tools, like you say, we've got everything we need. So where's the difference? What can we learn from COVID?
Thank you very much. I think this is an excellent question. And three things jump to my mind quickly about COVID. I think COVID was a huge pandemic, and it showed us the importance of the community. And in the COVID response, I became a community member myself, because for me to wear face masks, you need to convince me that it's necessary. So it brought to the fore the importance of mobilizing communities. And I think you will have some words on how do we further engage the hepatitis community to make a loud sound in this field. The role of integration of health services and decentralization of care and using shared platforms came out strongly in the COVID response. And funding, we've never seen so much money appear so quickly as in the COVID epidemic. So I'm just going to drop those three things here. But I just want to respond to the previous question as well. And I think we need to also look at hepatitis B and C from low-income countries and high-income countries, because the context, the infrastructure, the strategies will differ. And that is a nuance we need to put into our discussions. So let me hand over to you. Thank you.
Great. Thank you so much. Okay. I mean, we could carry this on for the entire time, but I think we're going to move on to our first segment. So in our three segments, as I said before, are really focused on those three areas that Dr. Leshy outlined. So we're going to start with prevention and vaccination and PMTCT and specifically talking about birth dose. So we're very lucky to have two fantastic speakers to start us out. So first we'll start with Micheal. Micheal, would you like to introduce yourself and tell us just an intro to your work?
Okay, thank you, Cary, and it's my pleasure to attend this webinar on behalf of Gavi. So I'm Dr. Micheal Besong. I work with Gavi as program manager for the hepatitis B birth dose vaccine program, the Gavi side. And I'm pleased to be part of this panel and to participate in these discussions.
Great, thank you. And Manal, would you like to introduce yourself, please?
Yes, my name is Manal Ghazzawi from Sierra Leone, founder of KnowHep Foundation. So in the main objective of the foundation, most recently is capacity building of healthcare workers, screening of pregnant females at antenatal care. And this year, in commemoration of World Hepatitis, they've already screened up to 390 pregnant females. So we've also been involved in, we're also involved in daily screening and vaccination in-house at my pharmacy at low cost. We also do free hepatitis B birth dose vaccination to babies at 2 maternity hospitals. We're also currently advocating by urging the government to introduce the hepatitis B birth dose. Thank you. It's a pleasure to be here.
Thank you so much. Thank you. So Manal, maybe we could just kind of continue with you and then we'll bring in Micheal in. So you've obviously been doing all of this work, kind of grassroots work with your organization. Maybe tell us a little bit about your experience in Sierra Leone about, preventing mother-to-child transmission and birth dose in a kind of pre-Gavi world.
Yeah, it's very challenging because currently the government is not providing free antenatal screening for hepatitis B. So yeah, the service is not there. They also have to use out of pocket money to be able to get treated and also for their babies to be vaccinated. So nothing is being done for free. And just like Fumi mentioned, it's all about writing strategic plan, but then when it comes to implementation, it remains a big challenge, and we are yet to go there, to reach there. Thank you.
Brilliant, thank you. And I think we were all very pleased and thrilled, really, to hear the news at the end of last year that Gavi is going to be commencing its hepatitis B birth dose program. And Micheal is part of that program. So it'd be great to hear from you, Micheal, about the program, what we can look forward to, and maybe a little bit about what it's going to look like when it actually gets started.
Right. Thank you, Cary. So it's my pleasure to speak about the Gavi hepatitis B birth dose program because as we all know, the hepatitis B birth dose vaccine, it's a proven and very important intervention to break the cycle of mother-to-child transmission of hepatitis B. Gavi may be new to the hepatitis community, but Gavi is an organization which has as main goal to save life and protect people's health by increasing the equitable and the sustainable use of life-saving vaccines, especially to ensure that these vaccines get to populations that will not otherwise have access to these vaccines, maybe because they can't pay for it or because they can't afford it. And as Cary rightly said, Gavi's hepatitis B birth dose vaccine program was launched this year on the 12th of June. So it means as of now, over 35 eligible countries can already access Gavi support to introduce the birth dose in their immunization schedule. And this will make the vaccine readily available to all newborn babies to be able to receive soon after birth. And I can speak a bit about the support that Gavi will be providing in this space, because Gavi's support will mainly include procurement of these vaccines. So thereby relieving the costs from the beneficiaries, procurement of doses of the vaccines. Gavi also works with manufacturers in collaboration with its alliance partners to ensure efficient as well as sufficient supply of this vaccine, because even if the countries need it and want to pay for it, if the vaccines are not being manufactured, definitely there will be a breach in supply. So one of Gavi's also main role on the other side, in collaboration with its alliance partners, UNICEF, WHO, it's kind of like doing market shaping work to be able to ensure that these vaccines are always in short supply for the populations that need it. And also another support that Gavi provides to countries is strengthening infrastructure to deliver the vaccines, because you could have the vaccine, but it will never be it might be difficult for to reach the last mile, or to reach the children that need it, because there is like a chain, or there are certain platforms that need to be put in place to ensure that the end users, which are newborn babies, get the vaccine. And especially for the birth dose, which is a new time point in the immunization schedule, and also considering that the vaccine is recommended to be given within the first 24 hours of life, it makes it logistically challenging. And Gavi provides supporting countries with the necessary, with providing basic support to be able to strengthen infrastructure to be able to ensure that the vaccine gets to the last mile. So in summary, that is that. And one thing which will be key in all of this effort is appropriate coordination, collaboration, and integration between all the main health services that are involved, be it maternity services, maternal newborn child services, immunization services, as well as hepatitis control, community health services. So all these main services or stakeholders who have work related to the hepatitis B birth dose will have to come together and work hand in hand to ensure the effective delivery of this vaccine. So I'm going to stop here, and yeah, thank you.
That's great, Micheal. And I'm sure that it's going to be music to so many people's ears that this support is becoming available. And I was wondering if you could just talk a little bit about Gavi's, because I understand that it's up to the country to develop their program in collaboration with Gavi and to deliver it. But what sort of role does the community organizations have, or what's kind of Gavi's view of the role of community within their vaccination programs?
Thank you, Cary, for that question. And yeah, it's true that the country has to prepare the application in collaboration with support from like WHO and present it to Gavi to be funded. But the communities play an essential role because one of the key elements required for the effective delivery of the vaccine, it's about educating pregnant women about the importance of the vaccine, as well as empowering them to request for it. So the communities, civil society organizations, community-based organizations will play a great role in raising awareness, engaging with the communities, engaging with pregnant women, with women of childbearing age, to make them to know about the vaccine, and for them to be empowered to be able to request it when they deliver, and also to bridge like different myths related to the vaccines or different bottlenecks which may be general hindrances to immunization in that community. So I would say that the community has a area where community organizations can really help to strengthen vaccine confidence, thereby ensuring the successful rollout of this vaccine.
Excellent, thank you. So Manal, kind of over to you, because you've been doing this work in an environment where this wasn't kind of provided, and you've just heard what the kind of proposal is. How do you think that'll affect your organization or organizations like yours who are already trying to support women in this in prevention of hepatitis?
Yes, I fully agree with Micheal with all what he has pointed out. And definitely we have to advocate, or we have to fight against or to debunk the fears or myths against vaccination, because that is very, very key. And as we all know, community engagement is key. And we shouldn't forget also to engage the traditional birth attendants also, because many women are already living in underserved communities. So there's no way we can actually convince them to travel miles to go and give birth. So they depend on traditional birth attendants, and it's important to engage them, to educate them about hepatitis and the importance of the introduction of the hepatitis B birth dose, and also to be able to encourage traditional birth attendants to be able to pioneer a strategy, or to be able for them to be educated about the fact that women that they are attending to should also be visiting antenatal care services. Also, it's very important. And I think Indonesia also has introduced the pre-filled vaccination, which does not need cold chain, which can also be very helpful for it to be introduced in underserved communities, or to be able to help with logistical challenges when it comes to transportation of hepatitis B birth dose to hard to reach areas. Thank you.
Great, thank you. Micheal, would you like to make any comments about out of facilities births, and how I know that I think this first round of Gavi is really focusing on in facilities birth, but like looking forward, what's Gavi's strategy or outlook on this? Thanks.
Okay, regarding out of facilities, because it stands kind of the strategies of what works for in terms of service delivery or vaccination delivery for children born out of health. It will be important to understand the implementation strategies which are cost effective and which could be easily deployed to be able to more effectively reach children born out of a facility. For that, having been out in the community like a research learning agenda to answer some of the questions. strategies that work in terms of reaching children born out of health facility. All have, I mean, different organizations, different settings are doing different things, but it will be good to have like an evidence base that, okay, this strategy works, cost effective, and it can be built up in different settings to be able to best reach out of health facility. That's the first step Gavi is trying to take to be able to bridge that gap, and subsequently the next steps will follow. That's what I can say with respect to children born out of facility.
Excellent, thank you. So if we do have any questions or comments from the attendees, please do raise your hand and we'll turn on your microphone. I think there's one question in the chat for you, Manal. If I can just, so my chat window is very small. Hold on one second. So are you seeing, Manal, are you seeing reduced rates and hesitancy as a result of vaccine misinformation from COVID times? So are you, I guess the question is, are you seeing more vaccine hesitancy for hepatitis B post-COVID?
Not really, but I see that the turnout for vaccination is increasing. But then if because I'm already collecting data to know about why people are coming for vaccination at my facility, for example, and they're mostly coming because they need the vaccine to travel. And some of them are also getting the vaccine because they need to protect themselves as they have relatives having the infection. So I think when you go to the grassroots communities, to underserved communities, those that are less educated, they definitely have vaccine hesitancy due to COVID, for sure. Yeah, but unfortunately, the ones coming in to get vaccinated who know about the vaccine belong to the educated community.
Great, thank you. So we have a hand up. Is it Japit or Japiti? Please, you can unmute yourself and ask your question or make a comment.
Yeah, thank you so much, Tim, Cary James, and Micheal plus Manal. I just have one question to Micheal. I'm Japete John Aquila from South Sudan. I'm Executive Director for Africa Hepatitis Coalition, who's a member of World Hepatitis Alliance. I did not pick the part that he was talking about how the civil society, WHO, and Ministry of Health can collaborate to develop their concept note or proposal for the Gavi birth dose initiative. Thank you.
Okay, regarding I said for because Gavi supports country directly, so usually the national PI manager to make a request and work with the different partners to be able to come up with an application which will be submitted to Gavi. So it's kind of like a collaborative effort which is led by the immunization, the EPI in the country.
Thank you so much.
Okay, thank you. Thank you so much. Thank you. So I think I have a Kamala, you wrote in the Q&A that you'd like to ask a question. Feel free to raise your hand or we can open your microphone. Can we open Kamala's microphone, please? But if you raise your hand, it'll make us easier to find you. Kamala, if we could turn on her microphone, please. We might have some kind of little technical issue. Kamala, you can unmute and ask your question. Sorry, Kamala, can you hear me? Are you there? There you are.
Hello.
Yes, please ask your question.
Good afternoon.
Good afternoon.
Yeah, I just want to ask this question because
So we're having kind of a problem hearing you. If you could maybe
I'm
be a
talking
little
to
bit
you, I
closer
have
to the
been diagnosed
microphone.
for over 6 years.
I'm very sorry, Kamala, but
But
we can't really hear you. if you could type your question into the Q&A.
It has taken a...
No, sorry, the connection is just not strong enough. If you could type your question into the Q&A, we'd be really happy to answer it. So we just have a couple of minutes left. So Toby and Adi, you can unmute and ask your question or make your comment. Toby, you can unmute. Okay. So maybe there is one more question in the Q&A. So maybe I'll just go to that. And Toby, if you have a question, you can put it in the Q&A as well, and we'll be sure to answer it. So John Smith in the Q&A box said, underserved communities, don't you think community pharmacy outlets can serve as a vaccination site, but pharmacy professionals need to be trained? National Alliance Against Hepatitis Sierra Leone will coordinate, implement with the support of the Ministry of Health and partners. The cost of the vaccine is a concern. So I think, Manal, you're quite well placed to answer this question. Would you like to make the first comment?
Yes, KnowHep Foundation is already in coordination with the Minister of Health because we're part of the National Task Force. But John Smith himself knows that we've contributed to formulation of these policies, hepatitis policy, but yet we are yet to implement what's in the policy. So the vaccine, yes, the vaccine cost is a concern, but then community pharmacies also definitely would be very, very important stakeholders when it comes to elimination of the virus, because we have lots of community pharmacies, we have drugstores that can actually offer the vaccine at lower cost compared to other private clinics. And most of these community pharmacies, they're also located at hard to reach communities also. If they're able, and it's done mandatory by government, for example, to say that all pharmacies must screen for hepatitis to the general population, then it would also be very, very good, and it's a way to elimination of the virus.
Great, thank you. So we're going to have to wrap up this section, but maybe, Micheal, you could just finish us off by just giving us some of the key milestone or timelines around the proposals, or the, what the next 6 months look like for Gavi and making proposals.
Right. So we received the first applications for the first 2 countries who applied on the 15th. That is currently being reviewed internally, but there is another round opening, which will close on the 23rd of September. And we've had a couple of countries who have already started working on the applications for this round. So there's great momentum, and countries are really interested in the hepatitis B bird dose vaccines. And we anticipate that the first introductions will be happening in the Q3, Q4 of 2025, as different countries apply and get approved. So for the next, so we have a deadline in application window closing in the 23rd of September, and another one closing just before the year ends, which will be reviewed in early 2025. And then subsequently, we'll have the normal Gavi application rounds, which the 3 normal Gavi application rounds. So all countries encouraged to prioritize that and to come forth with an application for Gavi support.
Great, that's fantastic, and amazing news that some countries have applied already. That's super exciting. So I think I'm just going to need to close this section, but thanks to our 2 presenters in this one. And just a reminder to everyone that WHA is actually working on some briefing sheet with Hep B Foundation around the birth dose vaccine and around the Gavi processes. So that will be out soon. But for now, thanks both of you, and we're going to move on to our next section, which is looking at point of care testing and testing innovations, and specifically around hepatitis C, because I think we all saw in that data that Funmi shared, I mean, the gap for diagnosis is still vast. And although, Hep C is doing better in some parts of the world and has a higher diagnosis rate than hepatitis B, we're still far, far away from where we need to be. So we need to think differently. We need to think, we need to be smarter and innovate in our processes around testing. So we have some great fireside chatters. So I think I'll just ask them to introduce themselves first. So let's start with you, Rachel.
Thank you, Cary. Yeah, so I'm Micheal Halford, and I am the current president of the World Hepatitis Alliance. I've been involved with the Alliance for, goodness, about 8 years now. And I'm really, really pleased to be here. I'm someone with lived experience, and I also, in my day job, I run the Hepatitis C Trust in the UK, and we employ 180 people, and 160 of those have got lived experience. Yeah, that's me.
Great. And Caroline, would you like to introduce yourself, please?
Hi, Cary. Hi, everyone. Am I audible, Cary?
Yes, we can hear you fine. Thank you.
Thank you. Hi, everyone. My name is Caroline. I'm from Peduli Hati Bangsa. Peduli Hati Bangsa is a nonprofit organization based in Indonesia. We are mostly working with community of people living with viral hepatitis, and also those who are co-infected with HIV. Thanks, Cary.
Great. Thank you so much. And we're really blessed to have two people from different parts of the world all doing really innovative work. So as we said before, like community testing from communities is one way that we can scale up testing faster and bring it closer to the communities. So maybe, Caroline, maybe you could just start us out on what your organization's approach to testing for Hep C and what your role what role you're able to play in Indonesia.
Yeah, thanks, Cary. So I'm just gonna give a little perspective on Indonesia. So in Indonesia, hepatitis C is a significant health concern, much more than HIV. The estimated number of people living with HIV in Indonesia is around 540,000 people, but for hepatitis C, the prevalence is 1% of the total population. Mind you that Indonesia is a country in which we have 250 million people, so meaning there estimatedly around 2.5 million people are estimated to be hepatitis C positive in Indonesia. It means that there are almost 5 times the HIV cases in Indonesia. But shockingly, only around 42,000 cases have been diagnosed so far. So 42,000 out of 2.5 million is just a fraction of number. So it is indicating that the large number of undetected cases in the population is still ongoing. So increasing the screening efforts is crucial because early detection. We all know that early detection can prevent severe liver damage and also reduce transmission rates. So that is the little background on Indonesia. So and then we recently had worked with one particular vulnerable groups in which it is in the prison system, and we had an opportunity to also do the screening for hepatitis C in the prison setting, and the prevalence is 5 times higher than the general population. So it's around 5%. So indicating that this underscores also the urgent need for targeted screening within the correctional facilities to identify cases earlier, and also it's while they are in serving the term, it also provides opportunity to provide medical care. So in providing diagnosis, however, it is very challenging because of the security issues of taking people outside of the prison settings. So bringing point of care testing inside the correctional facility is much more important than in the general population. For general population, people can always come to the in Indonesia we have the public health centers, for example, or the hospitals. But for people who are incarcerated, that they don't have the same opportunity, right? So bringing POC testing is much more important in the setting. in the 7 facilities that we have held our screening, so that's around 1,000 people, close to 1,000 people were diagnosed. And we have to do all PCR testing to confirm the virological, the pre-treatment virus, and then also to confirm also with the treatment. So it is part of the pre-treatment requirement. So for that, for those people, we have in Jakarta we have hospitals, but for that 7 facilities, they don't have all the 7 facilities that we held the screening for. They don't have any POC testing, so we have to bring blood samples outside from the to bring the blood samples from the prison settings to the outside of the prison settings. So innovation is much needed, not only on the targeted group screening. So screening is the first part, but then there's a second part to that. So in our experience, we need multi-sector support. At that time, we had doctors doing telemedicines. So that's another innovation. We also have to do, we were supported to do the lab, to cover for the lab costs, but also it means that the community can cover for the lab costs. And we also have government providing the RDT and also the PCR tests. But also there are also private settings and also private lab and government lab in running the blood samples. So is it doable? Yes, it is doable, but it requires collaboration and also much more. I cannot say it's harder, but it's more. In a positive notes, I might say it's more exciting opportunities to come. Thanks, Cary. I'll add much more on that. Thanks.
Oops, unmute myself. Thank you so much, Caroline, for that overview and of the amazing work that you do. So, Rachel, I'm going to turn to you now as CEO of the Hep C Trust, which maybe provides the most community-based Hep C testing of any organization in the world, certainly up there. And maybe just talk about your approach at Hep C Trust, and then since Caroline brought up prisons, maybe feel free to bring in that angle as well, or I'll just leave it over to you.
Yeah, thanks, Cary, and thanks, Caroline. I mean, it's an amazing piece of work that's happening across it, just full stop in Indonesia, but particularly across the prisons. I think there's something about, so at the Hep C Trust, we are, if we're talking particularly about people who sit outside, how do we find the undiagnosed and those that sit outside the traditional healthcare systems, we have to take the services to them. And I don't think that's just about the UK. I think that's the same anywhere in the world. We need to decentralize the services, the healthcare services for hepatitis. And it's really easy to do. We heard it just now around hepatitis B. It's happening from Manal. It happens in the pharmacy. And I think that it's about taking the services to the local communities. And placing those services in the local communities. And of course, I would always say, putting the people with lived experience at the center of that, because we often hear, and I think Fumi said it, that the community needs to raise its voices, but, we are a lot more than our voices, as we've just heard from Caroline. We are really good at delivering services. And when you're talking about people who sit outside services, they hear us, because we haven't said it yet, but one of the things that we can't not speak about is the stigma that's still attached to hepatitis. It's huge, and it has a massive impact on people accessing healthcare services, not just their own stigma, but the stigma they receive from the healthcare providers. So I think that there is lots to do around raising awareness around destigmatization, so kind of changing that conversation. And some of the things that we do here is we go out to the local community. So people with lived experience, we go out in vans, one-stop shop vans where there's easy access to testing. There's a short pathway to treatment. The tests, because these are people, a lot of the people we work with, they don't stay around for very long. They're not easy to stay, they don't stay engaged for very long. So that we do point of care tests, or if we are in a, if we're lucky and we've got a Cepheid machine, we can do a test and turn it around, within an hour. And I know that, having that is a very fortunate thing to have. But I guess my message in that and what we've learned in that is the shorter the pathway, the better, particularly when you're working with people who sit outside healthcare systems. integrated care, working alongside other community organisations, organisations where people access. Pharmacies are brilliant because, in this country, that's where people might pick up their needle and syringe provision. It might be where they're going for other information. Why can't we do the whole lot in one place? And then just to add on, in prisons in the UK, I mean, one of the things that we've done is that it's mandatory that every single person who goes into a prison is offered a test. So if you are testing everybody going in, then you are nearly everybody, then you have that captive population. We don't have the high prevalence like Indonesia, but we've done masses of work, and we now have a number of prisons where they have micro-eliminated, so they know that no one in that prison has got hepatitis C, and that's about regular testing. So it's embedding testing and joining them up, joining up the testing for hepatitis B and hepatitis C at the same time, and HIV, integrating services.
Excellent, thank you. So I guess, Caroline, I'll come back to you. I mean, you guys already do these great testing things, but what do you think would be, what would really make a big difference in enabling you to test more people, to reach more people? What are the barriers that need to be overcome, and what should we be advocating for to increase testing? What's your view in your country?
I think the two major things that will change is if the country is prioritizing hepatitis, that's one. And then two is like providing the policy, like everyone should be tested at least maybe once a year. This is much more important for hepatitis B in Indonesia because our prevalence is higher than 2%. So for people who are, the recommendation is that for a country that is that have recommendation of higher than 2%, it is required to have everyone just get tested, not only like some certain population, right? So yeah, I think policy and also funding. If we don't have the fundings, there is no way we can get at least the antibody antigen test. Yeah, so I think that those are the three most important things.
That's great. And in Indonesia, to do a point of care test, can a trained community member perform a point of care test, or does it need to be like a doctor or a nurse or?
No, not at the moment. But yeah, but I think that is something that we need to think about in the future. Yeah, Indonesia is the country with 17,000 islands, so it means that having the point of care testing in the place that much needed. Of course, yeah, like this is gonna be great. Like if we have like point of care testing to the place in which remote areas, like in the small islands, at least people can get the the services that we need. Thanks.
Thank you so much. And Rachel, I think in the UK, we have a long history of point of care testing by community, trained community members. Can you talk a little bit about that at Hep C Trust and how that works, and the benefits that you see?
Yeah, absolutely. I think, as I've just said, it's people with lived experience who are paid members of staff and volunteers, and they're trained to deliver the point of care test. It's not rocket science. It's not hard. It's a really easy test to do. So they complete the test. When we first started doing it, it was the swabs, the mouth swabs. But now, as time's gone on, we have staff out there who go out on the streets and they'll do, in a safe place, they'll do the instant point of care test kits. In addition, we've also got staff that are trained to use a second machine. So I think that my message here is that training somebody to deliver a test is really easy. I hear it, and I think that the biggest concern, I think, is, and it's very easy for me to say this because I'm in a country where it's a high-income country, and I'm really conscious, particularly with my time, with the Alliance, that there are very few countries that have that luxury. So it's about how do we make sure that people in, that other countries have access to. I remember being in a session, it was one of the African countries, and there wasn't money for test kits. So, we can talk about this is what we know we need. But actually, if there's no money, so where's the money coming from to ensure that there are tests so that we can then, treat people? So, I mean, I guess it's just, my message around it would be, for us, we do testing all the time. We are asked and supported by the nurses to complete the tests. So it's completely integrated into the healthcare systems and outside of the traditional healthcare systems.
Great. Thank you so much, Rachel. John Smith, I see that your hand is raised. Let's open John's microphone, please. John, you can unmute.
Yes, hello, good afternoon, everyone.
Good afternoon.
Yeah, thank you so much for the support. And I want to say thank you to my specialist, Dr. Manal Ghazzawi, for all our efforts so far in Sierra Leone. We've been in it since 2014. Regarding points of care testing, looking at the observation of all hepatitis D, we should be thinking around impactful activities. What I noticed for my country, Sierra Leone, the government, through the Ministry of Health and Sanitation, has done a wonderful job. We now have a national viral hepatitis policy. We also now have a treatment guideline for hepatitis B and C. And we also have a strategic plan, which is for 2024 to 2030. So a lot has been embedded into those documents. And just as my senior said, we need to now start to implement. So one of the impacts I am thinking about, I mentioned earlier on community pharmacy outlet, like what we have, City Group Pharmacy Outlet has been doing a lot in the private sector. But then looking at the government angle, it's key because we have hard-to-reach area and we also have primary care center across the country. And since it can be a rapid test that can be done, I think we need to reach more people. If we are to target elimination by 2030, we are now encouraging everybody to get tested. So once they test, the two outcomes, either positive or negative. For those who are negative, we are encouraging them to go for vaccination. But then the cost for the vaccine is a concern. In the private setting, the cost is different. So the government angle is another thing. So if Gavi can work or partner can work with the Ministry of Health and Sanitation, let's see how we can work on that. It's nice. But again, the hepatitis B vaccine is not free. For adults who have not ever taken vaccines, I'm sure most of them want to try to take it, but the shortfall gets 3 shots to complete it. It's a concern. So I think we need to look around that cost, whether we're going to have access to vaccines that are affordable. That will be key, both in the private sector. I think that will be key, and probably in some government facility. And when we talk about treatment, we have specialists who is Dr. Suleiman Lako. Fortunately for him now, is the Directorate of Disease Prevention and Control, and he's working to establish the Hepatitis Task Force unit to be on its own so that we can be able to carry out activities. So those who are positive, we have to lead them into treatment. There is a partner in our country we call Partners in Health. They have been working in the provinces so far. They have been trying to see patients who are positive to lead them into care, because leading somebody into care need a lot of issues, confidentiality, and proper care. So if we are to tackle viral hepatitis by 2030 in my country, Sierra Leone, we need collaborations, we need to work as a team, and we need support. And above all, we need to make the point of care testing available. The community pharmacy outlet we have, like the drugstore, we have pharmacy technicians and we have pharmacists who are in these places. Once they are given basic training, as long as they can do tests for malaria, they can definitely also do tests for hepatitis. Then we can have a database probably where we collect data for those who are doing it at various points. There, at the end of the day, we will know what we do. I am talking from the angle of the National Alliance Against Hepatitis, because since 2014, we have been raising awareness. And the concern of the public when we got to the radio station is what has been done. So for me, it's a many thanks to the government, but implementation is key. So the Global Hepatitis Alliance, World Hepatitis Alliance, all other partners fighting to eliminate hepatitis, I think we need to work through the government as well as those other organizations within the country, like the KnowHep Foundation now, and also the National Alliance Against Hepatitis, and we have Sierra Liver Foundation as well, and others as well. Then trust, I'm sure we are going to increase the coverage of testing, because I'm sure the key point for us to eliminate hepatitis, we have to go for tests. Another point I will raise, there are some family that times we call that you want them to visit home and then do private testing, because maybe others might not want to come into public facility. That's a mobile service. I think all that we can go through, but at least I will share an email. Maybe you got access to the hepatitis policy, the strategic plan, to see how we can implement, because we have 16 districts in Sierra Leone. If we can go to each of these districts, raise the awareness, ensure we tell them to do the test, then definitely we will be able to eliminate hepatitis in Sierra Leone. So to Gavi, I don't know for the application for the vaccine, if there is a link they shared, at least the directorate will work on that, because the last time we discussed that on meeting to see how we can meet on that and do something to eliminate viral hepatitis by 2030. Thank you very much.
Thank you so much for those comments. I'm afraid we do need to move along, but I think just in terms of the theme of innovation, I mean, I think a lot of you would have seen that there was the first hepatitis C self-test pre-qualified this week, which is very exciting. And so we just hope that that's going to be the first of many at different price points to make this available. And I think there's lots to discuss in terms of but then maybe that's another webinar. But I mean, the World Hepatitis Alliance acknowledges the huge importance that testing plays and how we need to do more. So from our point of view, someone just share the slide. We're starting a new initiative that we hope all of you will participate in, called World Hepatitis Testing Week. So this will be an opportunity for all WHA members and other stakeholders to come together to really increase testing in their areas by having testing events, but also be an advocacy point to work on all of those policy obstacles that we know exist. So we're very excited about it. There's planned for November. We will have a website live. We can put a link in the chat to the webpage if it's available. And we'll be launching the campaign and the materials later in the year. And that will include, very much like we do for World Hepatitis Day, posters, social media assets, messaging, and toolkits to help all of you hold successful testing events, but also advocate for more testing in our area. So that's one thing that the World Hepatitis Alliance is doing to try to turn the tide in hepatitis testing. So with that, I think we'll move on to our next session, which is about treatment. And specifically, we're going to start with hepatitis B treatment. But if people would like to make comments in the chat or other place about hepatitis C treatment, you're very welcome to do so. So at the fireside, we have two fantastic experts. So I'm going to ask them to introduce themselves. So Dee, could you introduce yourself first, please?
Hi, this is Dee from Asia and the elected board member of World Hepatitis Alliance for the WPRO region. I've been fighting stigma discrimination against people living with hepatitis since 2010 in China and now predominantly in Southeast Asia. So we run all the work through the case management, each case by each case, legal action, and media campaign.
Great, thank you. And Patrick, would you introduce yourself, please?
Thanks, Cary. Thank you for the introduction. It's a real pleasure to be here and to be part of this really outstanding webinar. My name is Patrick Kennedy, and I'm a hepatologist based in London. I have a long track record in hepatitis B research and translational research and looking at why we should be treating more patients with chronic hepatitis B and looking at kind of immunological reasons for this and access and improving access to care. So it's a real pleasure to be involved in this webinar. Thank you.
Brilliant. Thank you so much. And I'm sure as many of you will be aware, there's been a new WHO guideline this year around hepatitis B, which does increase the eligibility for treatment. But now, of course, countries need to adopt their own policies. And of course, the main, kind of big academic scientific associations will also adopt their own guidelines, and those kind of have regional focuses. So there's going to be a lot of discussion and movement in this area in the coming months and years. But I think maybe it would just to kind of set the stage for the conversation. Maybe could you just talk about like the importance of treatment to someone who is living with hepatitis B, the kind of impact it has on individuals and your kind of, experience. Thanks.
So I'm so glad that we have, Patrick together with me on talking about one fact, two sides of one fact, because Patrick will be more on the scientific aspect, and I'm more on the practical, or maybe like more on a humans engagement. So treat all is such a expected atomic bomb for the hepatitis B sector, since we've been knowing some days are going to come. But to be fair, the community, at least the organization in VPRO regions, are not expecting the treat all guideline will be coming much quicker than we thought. So yes, I do think that we should treat more people living with hepatitis, especially for me, that I'm begging every day that we have more solution, we have more resources injecting into the sector, but we have to come to on the practical situation. The priority is always a must, and we should do it gradually to treat all. So when I talk to the policymakers and hepatology experts in China, Taiwan, Thailand, and Vietnam, and some of them are even the writers of the guidelines, there's so many concerns over the place, crashing the medical system, not enough of medical staff, or some of them even saying that we should wait for the functional cure to officially launch the treat all strategy. And since we don't have the functional cure yet, when we talk about the industry and pharmaceutical companies, they are not keen on any sort of negotiation on the drug price, patent, exchange or something like that. So I also conducted a survey probably 1 month ago with 433 samples for the people living with hepatitis. Imagine that 89% don't really know what is treat all really means. And 49%, nearly half of them, let's say nearly half of us don't really care. It's either treat all, maybe just treat me. So it sounds very interesting. We know treat all is necessary for us, but sometimes most of the people, the majority of the people living with hepatitis, just need treat me.
Great, thank you so much. So Patrick, we'll turn to you. Like Dee said, you're a hepatologist and a clinician. Like, from your point of view, should we be treating more people with hepatitis, and why?
Yeah, thanks, Cary. I mean, look, Dee's made some really, really important points around treatment. I mean, the whole discussion here, I'm just so happy that we're actually having this debate, because it's a very simple answer that should we be treating more patients, and that is yes. We know some very good data looking at modeling, for example, for the development of liver cancer. And liver cancer, as a consequence of chronic hepatitis B, is set to double by 2040 from where we are just in the kind of pre-2020s. So as a treating, clinician, I look at this and go, well, what is the one thing I can do to prevent my patients with chronic hepatitis B and chronic hepatitis B patients globally, people living with hepatitis B, from getting a liver cancer? Well, certainly one really important intervention there is treatment. If you treat patients and you treat them early enough, you reduce viral load, you reduce integration of the virus, you reduce inflammation, you reverse fibrosis. And by doing all of these things with a simple available nuke, you are going to put those individuals in a much safer position with a significantly reduced risk for the development of liver cancer. So as a treating clinician looking at this and considering how we approach treatment for patients living with chronic hepatitis B, the simple answer, as Dee said, we need to treat many, many more patients. We've got a very good reason to do this, and we've got very capable drugs which work very well, even outside of the whole functional cure program, because the functional cure program is still going to take some time, but we can use what's at our disposal right now.
Great, thank you so much. And just in case people aren't aware, in addition to WHO guidelines, China has introduced a guideline which is basically a treat-all approach. So, first test, offer them treatment. And I think because I'm at the AIDS conference here in Munich, and obviously it's the same drug, TDF, that's used to treat hepatitis B that they use in HIV for also for HIV treatment in a combination, but also as HIV PrEP, so to prevent people from getting HIV. And it's very readily available. Do you know what I mean? Community-based organizations will, dispense TDF after a short consultation without a doctor or a nurse present. So just help us, maybe Patrick, can kind of help us understand, why it seems to be so easy for some people to, in terms of HIV prevention, to get this drug, and it's been so difficult for people with hepatitis B to get it.
Yeah, I mean, look, Cary, you touched on a really important point and observation. Personally, when I look at this, what you see is a very clear dividing line between, let's say, hepatologists, liver specialists, gastroenterologists who may be treating viral liver disease compared with infectious diseases, people treating HIV. And, there's a clear differentiation there, but it's time, and the time is now, that we change these approaches. I agree with you that up until now, guidelines were probably overly complicated. We talked about WHO, which has changed. You talk about the Chinese guidelines. Anybody aged over 30 with detectable HBV DNA should be offered treatment. These are very simple messages. These simple messages are also going to emerge in the new EASL guidelines, where the barrier to treatment is being reduced. So if you give that picture of how HIV can be managed, D is talking about treating, a treat-all approach, and I'm saying we should be treating more patients. You can see that at every corner of this debate, we all agree we should be treating more individuals with hepatitis B. And how do we do that? By doing that, we go to some of the discussions that we had earlier on about a much more integrated pathway of management. We heard Manal talking about the community pharmacies. We heard Rachel also talking about these concepts of integrated care, where, you don't have to be a doctor to prescribe an antiviral. You just need to be part of a team, and a team that is responsible for the oversight and the management of an individual living with chronic hepatitis B, and that everybody is fully informed at every stage of this. The individual knows what's to be gained by taking an antiviral. The treating healthcare practitioners know what's involved, the monitoring, the risks, etc. And as long as that's communicated, I think we'll make a lot of progress in moving this forward.
Excellent, thank you. So Dee, maybe to come back to you and your experience of working with people living with hepatitis B, some of which who will be on treatment, some of which who still aren't. And I mean, I just try to imagine what it's like to be told that you're living with a chronic condition that, that there's a high, a relatively high chance of developing into a liver disease, but you're not going to be given the treatment until sometime in the future. So just can you just reflect a little bit about the impact on treatment and how going on to treatment can affect the way that people living with Hep B view themselves and the condition that they're living with?
I think when it comes down to the situation on a daily situation for the people living with hepatitis, I mean, giving a very vivid example is me. I'm living with a ticking bomb, even though I'm not on any treatment now, but still, I'm the high risk group of the population, one of the population high risk group for HCC. So when it comes down to, when we heard about the treat all, my concern is always that we need to be ready to launch the treat all strategy. So a couple of things I'm really interested in, talking about is one, we need to increase the scope and depth of the awareness and community education. So as I said, we are living with a ticking bomb on a daily basis. Why do we need to get treated if we are not able to really fully understand that, the hope is near, that you will be a happy, free person. But honestly, the message is really, badly transmitted to the community that we're so far away from getting the, a functional care. And also the surface delivery system needs to be well constructed. So when we talk about, maybe we don't have such a situation in China, but when I went to the Vietnam, or maybe the northern part of even go to Thailand, or maybe I just came back from Cambodia. The service delivery is really, let's say, poorly constructed. And yes, people keep saying that, the industry, the community keep saying that we got everything ready, but to putting them together efficiently, putting them efficiently to be, deliver all the service to the people living with hepatitis is so difficult. It's a very challenging task, geographically and economically. So it is not easy to, we know that, the hope is there, but we also know it's so difficult to really get what we want.
Thank you so much. Okay, so I would like to open it up to the floor for attendees. If anyone has a question or comment, please raise your hands. I mean, I think the really stark thing also from the data that couldn't be presented is, I think the overall Hep B diagnosis rate is 13%, but that really masks, when you look at it regionally, like CRO, it's 2.8%. And of those, 0.1% are on treatment. So even with the current guidelines, we're treating far below what we should be. So I think there's so much work that needs to be done. But I'm going to go, I see a couple of hands. Dr. Golem, please. Dr. Golem, you can unmute your microphone.
Yes. Greetings of the day. I'm Dr. Golem from Godfrey from Uganda, and I am a clinician, and at the same time also take part in seeing hepatitis patients in one of the chronic hepatitis clinics, and also an infectious disease consultant who does more of advocacy on the ground for viral hepatitis. This is first of all, I am happy that my colleague Patrick, Dr. Patrick Kennedy, and of course the passionate and the ardent D Lee, who is always driving the agenda from time to time. I want to congratulate and appreciate, and of course, and not forgetting, of course, the champion himself, Cary James. So for me, I want to give a few perspectives. On the treat all strategy, particularly when I take a case study of Uganda and the patients actually that on daily basis we come across, and then we follow them for 2-3 years. The next thing you see is coming back with the cancer, and the next year you see is gone, and it's extremely saddening and tragic that we continue to lose what we should have. We continue to lose lives prematurely that we would have actually saved. So so I also want to add that what the aggressiveness or the shift that China has just done in terms of strategy is really the way to go, and it's critical. And I think when it comes to the concept of the concept of integrating care, it is the biggest challenge that Uganda currently is facing, because we we do have a robust hepatitis B strategy or roadmap in Uganda, but we do not have any for hepatitis C. As we talk now, the country does not have anything on hepatitis C. So and yet hepatitis C is curable, and nobody, I repeat, nobody is supposed to be allowed to succumb to any death as a result of hepatitis C. But we are witnessing a lot of unnecessary deaths, even when we have the policy and the guidelines reviewed from time to time, including also screening strategies becoming simpler and simpler, involving component of self-care testing and all that. Yeah. So, but my big issue here is in terms of three or four barriers. One is with of course differences in the health service delivery models. The health service delivery systems, particularly in Africa, are not
So I don't know if it was my connection or have we lost Dr. Gollum?
Hello?
Oh, I think we can hear you again. The connection is quite bad, Dr. Gollum. If you could just finish up and then we can
Okay. Let me summarize. I think my summary basically is in terms of in support for treat all strategy and the issue of actually integration. But the concept of integrating care has just been in the mouths of people, but practically it is not happening in the communities, particularly when it comes to interests of funders. I can give you an example that when it comes to HIV, there's no country that beats Uganda in terms of HIV models globally, but it's still the hepatitis care clinics are still operating in silos. They are not being integrated with HIV, with HIV care the clinics. And when it comes to medicines, to actual antivirals, it's worse, because a same person who has been screened for hepatitis B cannot access medicines from a same clinic that is actually serving HIV patients. So it really beats our understanding. Over. Thank you.
Thank you so much for making those really important points. We're just at time, but I'm just going to carry on for 5 minutes. So, Dee, would you like to make some final remarks?
So, thanks, Dr. Gollum. I really appreciate that all the. So I'm really saddened about the fact that Hep C is not really aware in Uganda. So at the moment, if you are asking me any thing we can do to turn the tide for the access of hepatitis treatment, regardless of B or C, the only one thing we can do is to leveling up the emergency for hepatitis. Now the governments are sitting on a seatbelt relaxed mode, and the industry is tilting the resources on liver cancer, mainly on HCC, and our voice is not unified and strong enough. So maybe in the community, some say we need a better healthcare system, or maybe we need a testing system. But when the message is not unified, it's difficult for us to putting all the pressures on the policymakers and the farmers and industry. So my only strategy is by pulling out the sympathy strategy that has been very, very well played in the HIV/AIDS, TB, and STI sector. So that's why we know we are able to know that people in Africa are dying on daily basis in such a high preferences on Hep C and Hep B, and also the people living with hepatitis in China, even though we have the such a low prevalence on the infants under age 3. But the people like me, there's still like 50 to 60 million people. We are getting older and older. So this kind of sympathy strategy can really help us to know us more and giving pressures to our policymakers to make sure that just don't sit back and relax and putting all the resources on hepatitis. So we've been waiting for 13 years already since the first World Hepatitis Day. But we need to take more action. We should do something bottom up. We should, we are lucky enough to wait for the Hep C drug, but what about hepatitis B? So we need to take action as communities. We shouldn't wait. We need to take action. We've been waiting for 13 years. We're not waiting anymore. Thank you.
Great. Thank you so much, Dee. And Patrick, your final thoughts.
Yeah, no, thank you, Cary. Look, I couldn't agree more with Dee, and Gulam's comments are really important. I would say, just this kind of closes it up because Funmi talked earlier on about saying that we have the tools. We do have the tools. The guidelines have changed dramatically. There's no like clinical excuse anymore for not treating patients. The message is we want to treat more people. We want to treat more people, put people in a safer place, reduce the risk of disease progression, liver cancer. We have the means to do that. We need to start working as a community to deliver that and to disseminate this information like Dee said. Really important. Thank you very much.
Excellent. Thank you. And thank both of you and all of our panelists today. Just a reminder that WHA has produced a community briefing on the new Hep B guidelines, what community members need to know. We're going to put the link in the chat right now. And we recently published an opinion piece in the Lancet on the Treat All approach, which you can also read. We'll put the link in the chat below. And I'm sorry, John, we're not going to get to your comment, but please put it in the chat if you have time or email it to us and we'll get your question answered. So just a final thank you to everyone and a reminder that World Hepatitis Day, if you need it, reminding is Sunday. Please put up the slide, please. And that the theme this year is It's Time for Action. And there are many resources available on the World Hepatitis Day website, worldhepatitisday.org. So please visit the website, download materials, make use of them. And we hope you have a really impactful World Hepatitis Day. And just to close us off, we would just like to play for you our World Hepatitis Day video that we made for this year, which I think really encapsulates the spirit and the sharing that we did in this webinar and what we really want to achieve as a community in hepatitis. So let's play the video. Thank you all very much, and we'll see you all again soon.
Hepatitis is now the world's deadliest virus after COVID-19. It claims 1.3 million lives each year, and the number of deaths is rising. There is no time to waste.
It's time for action.
Leaders, it's time for action.
Politicians, it's time for action.
Doctors, it's time for action.
Communities, it's time for action.
This World Hepatitis Day, 28th of July, we must all take action.
Test.
Treat.
Vaccinate.
Visit worldhepatitisday.org.
Thank you all very much and see you next time.